Heart failure is an abnormal condition involving impaired cardiac pumping and filling. As a result, the heart is unable to produce an adequate cardiac output to meet metabolic needs. Other forms of heart disease are actually coming under better control, but heart failure is actually increasing in incidence and prevalence. This increase is due to the fact that more people are surviving after cardiac events that have caused cardiac damage, and also the population continues to age. Heart failure affects about 5 million people in the United States and is the most common reason for hospitalization in adults. Heart failure can be classified according to either functional classification or disease staging. Functional classification is the most commonly used system. Class 1 and 2 are less severe, though a Class 2 client does have symptoms. Classes 3 and 4 have severe activity limitations, and Class 4 may have symptoms even while at rest. The disease stage system is much the same, but it focuses on actual physical changes in the heart rather than client ability. A stage D client may require either hospice care or a heart transplant. You should become familiar with the presenting symptoms of heart failure. Left-sided failure. You have dyspnea on exertion is often the first clinical sign. Appearance of an S3 called ventricular gallop is an early sign. Other signs include orthopnea and paroxysmal nocturnal dyspnea, which is acute shortness of breath caused by lung congestion and edema. It occurs suddenly at night, usually an hour or two after falling asleep. The client wakes up gasping for breath. There may be also pulmonary edema. Pulmonary edema is an acute, life-threatening symptom in left-sided heart failure. With right-sided failure, there is lower extremity edema. Increased volume and pressure develop systemically in the veins, so the symptoms occur peripherally. Jugular venous distension is visible more than a few millimeters above the clavicle when the client lies supine and raised to a 45-degree angle. Abdominal discomfort and nausea occur from fluid congestion in the abdominal organs. While failure occurs on both sides, it does cause unexplained symptoms: unexplained fatigue, decreased exercise tolerance, and unexplained altered mental status. Do not worry too much about these tests because you will actually study them in detail later in the program. I'm only briefly introducing them here because there is a possibility that you might run into them during your clinical rotation. Of course, you've already heard of a chest X-ray. In this case, it is used to help to diagnose cardiomegaly or vascular congestion. Echocardiogram is basically an ultrasound of the heart. It will show decreased ventricular function and decreased ejection fraction. A CVP is central venous pressure. It is considered a direct measurement of the blood pressure in the right atrium and vena cava. It's done by threading a catheter through a large vein and into the heart. Pulmonary arterial blood pressure monitoring may be used to guide treatment in a serious case of pulmonary edema. It is used also by placing a catheter into the heart. In the acute phase, you must monitor and record blood pressure, pulse, respirations, and ECG. CVP is central venous pressure, and PCWP is called pulmonary capillary wedge pressure. They are measurements done by catheter. Again, you will study these in detail during your critical care rotation. Maintain the client in a sitting position to decrease pulmonary congestion and facilitate improved gas exchange. It is important to auscultate heart and lung sounds frequently. Increased crackles, increasing dyspnea, decreasing lung sounds, or a new S3 heart sound indicates worsening failure. Administer oxygen as ordered to improve gas exchange and increased oxygenation of the blood. Monitor arterial blood gases as ordered to assess oxygenation. Administer prescribed medication on an accurate schedule. Always remember to monitor serum electrolytes closely to detect for hypokalemia that may occur as a result of diuretic therapy. Monitoring accurate input and output is crucial to evaluating fluid status. This may require a Foley catheter to allow for accurate measurements of urine output. If fluid restriction is prescribed, spread the fluid allowance throughout the day to reduce thirst. Provide a calm, reassuring environment to help to decrease anxiety, because it will decrease oxygen consumption and decrease demands of the heart. Chronic cases, we work to educate the client and family about the rationale for their therapeutic regimen. We may be asking them to make changes that they don't want to make, so they are far more likely to do this if they understand why it is necessary and how it will benefit them. Establish baseline assessment for fluid status and functional abilities. It can be baseline normal, or some clients with heart failure to have bilateral crackles in the bases, or some level of peripheral edema, or to be unable to walk more than a specific number of feet before tiring. You need to know this so that you are easily able to determine when there has been a change. Monitoring daily weights is a very significant intervention to evaluate changes in fluid status. Assess at regular intervals for changes in fluid status or functional activity level. Stroke volume is the amount of blood ejected with each contraction of the heart. It is dependent upon the preload, which is the amount of fluid in the ventricles at the end of diastole. If the heart muscle is weakened due to heart failure, we can improve the situation by reducing the work it has to do, and we do that by manipulating preload. We first reduce preload as the first component of drug therapy by using a diuretic. We won't dwell too heavily on drug therapy. You will cover this in detail during your pharm class. But briefly, angiotensin-converting enzyme, or ACE inhibitors, are used to decrease preload. They act as vasodilators and promote sodium and water excretion. And because they are vasodilators, they also work to reduce afterload. The amount of afterload is a concern because it is the ventricular pressure at the end of systole, the force the heart must pump against. Diuretics, often loop diuretics such as Lasix, are given to decrease pulmonary congestion, which in turn will decrease cardiac work and improve cardiac output. Less fluid means less work for the heart and more efficient output. Nitroglycerin may also be used as a vasodilating effect as well. Morphine is used to sedate and vasodilate, which decreases the work of the heart. Digoxin slows and strengthens the heart, which increases contractility. Remember to take an apical pulse for 1 minute and hold digoxin if the heart rate is less than 60. Include family members or others in teaching as appropriate. Teach the client the importance of measuring and recording daily weights. Make sure they understand that they need to weigh with the same amount of clothing at the same time of day. It should report any unexplained increases of 3 to 5 pounds. Weight change is the most sensitive indicator of increased fluid overload. With diet, sodium is restricted to decrease fluid overload, and potassium-rich foods are encouraged to replenish loss from medications. Restricting water intake will not decrease fluid retention, so water is not restricted unless directed by the physician. With medications, explain to the client the importance of following all medication instructions. Remind the client that although frequent urination is a pain to deal with, regular diuretic therapy prevents fluid overload and acute exacerbations of congestive heart failure. Instruct the client to how to take a radial pulse for a full minute before taking digoxin. They should call their doctor if their pulse is less than 60 or greater than 120. With activity, help them plan how to pace their activity to maximize available cardiac output. Symptoms. They should report to the MD promptly any of the following: chest pain, new onset of dyspnea on exertion, or paroxysmal nocturnal dyspnea. Tell them to report even minor changes to their MD or home care nurse because they can be early signs of decompensation.